Welcome to this talk by Professor James Galloway on rheumatic disease and case discussions. So James Galloway is an academic rheumatologist and honorary consultant at King's College Hospital. His research focuses on big data, epidemiology, health outcomes, and clinical trial design. Clinically, he specializes in inflammatory arthritis, sarcoidosis, and rare rheumatic diseases. Now I'll hand over to Professor Galloway.
So thank you. So you are a very select group of you on here, and I know this has been recorded, so some people may watch it asynchronously, but I'm very happy for you to interact with me as we go through. I've got a series of cases that I hope will achieve two things. One, it will give you a flavour of what rheumatology is like, and the other is it'll just guide you through a bit of teaching around some sort of core medical subjects that may help you with an exam at some point. The photo you heard me mention about, this is King's College Hospital, which is in South London. It's if you know London, it's about 1.5 miles, 2 miles south of the river. If you don't, you probably heard of Brixton. That's probably the local landmark that is where King's is near. I've got 4 cases that I have seen at King's College Hospital. These cases were not all seen on the same ward round, but that doesn't matter because they're quite good cases. I think if you want to get the most out of these, though, the cases I have chosen are not necessarily simplistic cases. So I pay attention. Maybe switch your phone off for half an hour, and these are not supposed to be easy cases, but I will try and navigate through them with you. So this is the first one. This is a 64-year-old man who I got asked to see. He was on one of the medical wards. He had been admitted a couple of days earlier under the medical take with confusion and also back pain and cytopenias. Now, I don't know what year of study you all are, so I will explain bits as I go in the terminology I use. So cytopenia, that means that when he had his full blood count done, his blood indices, like his red cell count, his hemoglobin level, his white cell count, and his platelet counts were low. There's a bit of history about him that I will give you. So he's, although come in over 48 hours, there's probably a bit more of a background to him. He was confused, so not able to offer much himself. He was disorientated in time, place, person. He was feverish when he came in, and the photograph on the right, you capture someone who is gaunt, cachectic, thin, very little muscle, looks like he has been ill for quite a long time. And on examination, there wasn't anything on the physical exam that identified a clear pathology. The working diagnosis at this point was that the confusion was delirium, and unlikely due to an infectious process. So he started on a broad spectrum antibiotic that would cover a chest infection or urine infection, the most common forms of infection in presenting in someone with delirium. A bit more information became available. So we heard from his GP. He'd actually been to his GP quite a few times over the last few months with back pain. So actually the first episode with his GP was nearly over half a year ago, about 8 months ago, and his GP had requested an MRI scan of his spine. That was normal. There's some more information from his wife as well. His wife shared that his main problem has been the back pain. The confusion is a much more recent thing. It's not absolutely acute like it originally thought, 48 hours. She thought she had noticed his confusion about a couple of months ago, about 8 weeks ago, although initially it was just episodic, getting muddled about finances, getting confused about who they were meeting, and then it started to become more persistent confusion. Over around the same time, he's had enormous amounts of weight loss. He had lost over 15 kilos in weight, and he had been having night sweats. Night sweats, in my mind, always from if you're thinking about differential diagnosis here, you think about malignancy, cancers like lymphomas for night sweats, back pain, night sweats. This all sounds suspicious, but let me show you his lab data. So the lab data was notable for pancytopenia. So his hemoglobin is low, 86. His white count was low at 2.1. His platelets on the low side at 141. The other thing, he's got a CRP elevation, so he's got something inflammatory going on. And like many admissions, on admission, he has a chest radiograph. Just before I leave that, just on the bloods, I know some of you will be aware there is a national licensing exam, the MLA, which comes in the form of a single best answer exam, 200 questions across 2 papers. And the type of questions that come up in that exam will often include data for you to interpret. That often includes blood results. And a question I sometimes hear from medical students is, do I need to learn normal ranges? And my recommendation to you is, I think the answer will be yes for the most common things. They will always present normal ranges in these exams, but if you know the normal ranges for the most common indices, that will help you. It'll be advantageous not just in the exam, but when you first start as a doctor, just being able to immediately look and eyeball a blood result like this, and hemoglobin 86. I don't need to know the normal range. I know straight off that is low. It's substantially below where it should be, but it's not low enough that I'd want to do a transfusion. Look at the white cell counts, and I'm looking at the neutrophil count and 1, and that is not just low, but that is low on a threshold that I am worried about it. And the platelet count is low at 143, but it's not at a threshold where I would expect that to cause bleeding. So when you look at these, it's really key that you look at these, look at the normal ranges, but some of these results, like the hemoglobin, the white count, the platelets, the creatinine, the CRP, they should immediately jump out without having to look up a normal range. Lots of the other tests that you will look up a normal range are fine, but the core ones will be worth knowing without. Here's a chest radiograph. Now, this is a chest radiograph, and I'll just let you have a glance at this for a minute, because it's really useful being able to navigate a chest radiograph, anything abnormal on the chest radiograph. So when I'm looking at this, the first thing that strikes me is there's some abnormality on the right-hand side of the screen, his left, sort of circular, and it looks like there's maybe some sort of cavity. But let me just walk you through the chest radiograph. So I'm going to start, and I'm going to report this as if I was a medical student presenting this in an OSCE. So this is well, it doesn't say if it's PA or AP, so I'm going to assume it's a PA projection, posterior anterior projection film, taken of, and I've got the patient's details, and it was taken on this date. First of all, it's a reasonable quality film and doesn't appear rotated. I'm saying that because I can see that the spinous processes are roughly equidistant from either clavicle head, suggesting it's not rotated. Looking at the trachea now, the airway looks normally located. I can see the bifurcation, and I can't see any obvious shift of the trachea or abnormality of the bifurcation. So airway looks normal. B, breathing space, the lungs. So looking at both lung fields, I can see there is aeration of both lung fields to the edges, so there's no sign of a pneumothorax. I can see no sign of any pleural effusion at either corners. Just looking at the lung fields themselves, there does appear to be some patchy, soft tissue dense opacification on his left-hand side in the mid-zone, possibly some more subtle opacification in the periphery in the mid-zone on the right-hand side as well, just there, although I'm not sure if that's definitely opacification or confluent shadow. Looking at the cardiac contours, they look, doesn't appear to be any cardiac outline abnormality, and the cardiac isn't enlarged. And the cardiac contour is not enlarged. And then diaphragms, there's no free gas under the diaphragm. On this side, I can see the gastric bubble. Don't ever forget to look at the bones. I can't see any lytic lesion of any bone. Looking at the clavicles, look at the rib cage, can't see any bony abnormality here. In summary, it looks like we've got a probably pulmonary opacity on the left-hand side in the mid-zone. I hope it's useful when you're just thinking about how you look, how you talk through a radiograph like that. Causes of an opacity, I'm thinking lung cancer, but now also weight loss, fevers, night sweats, lung cancer, or the other thing would be an infection. I'm hoping some of you are thinking about tuberculosis at this point. Got an ECG. His ECG is not particularly informative diagnostically. This ECG shows he's got, well, it's sinus rhythm. Just looking at the rhythm strip, and I can see there's a P wave, QRS, P wave, QRS, P wave, QRS. So you've got a P to every QRS that's in sinus rhythm. It's regular, same spacing between each of the QRS complexes. If I'm looking at the QRS complexes, they are narrow, quite large complexes. You wonder whether he's on the borderline of having some ventricular hypertrophy, but it doesn't meet the voltage criteria officially. And then looking at the ST segment, it's sloping, but there's no ST segment elevation. There's no T wave inversion. They look quite tall T waves here. I would like a repeat ECG, but I don't think there's anything on this ECG that's going to make me think there's anything acutely cardiac happening. Back to the patient. There's a bit more history. He is a retired chief executive of a charity. He was born in South Africa, moved to the UK after school, but worked for 22 years in Cameroon. For those of you that don't know Cameroon, if you take a map of Africa and you're looking on the left-hand side of the map, the country it comes up and then it goes off to the left, that corner where you hit into Nigeria. Cameroon sits right in the corner there. It's a tropical part of Africa and an area where certain infections, particularly tuberculosis, are common, they're endemic. Just to go back to our patient, on examination, no lymph nodes, but he does have an enlarged spleen. So on examination, it's particularly when examining his abdomen, when you palpate the abdomen, you don't feel very much, but percussing over the left lower sternal margin, the rib cage, it's dull to percussion. And he's got a spinal mass. I'll just make a point to highlight this, that this was not picked up on his admission examination because he hadn't complained of any tenderness on his back. He'd been complaining of back pain in general, but examining the spine, there was no focal tenderness, but there was a visible mass, like a soft tissue lump that was palpable. And it felt fluid-filled. So we've got a repeat MRI. Remember, his MRI scan 7 months ago had been normal, and this is the repeat. And the repeat MRI scan here shows, well, first of all, so we're looking, this is his back. On the other side, this is his towards his stomach. And here, this is the spine. And you can see the normal curvature of the spine. Something very odd has happened there. And then this is also not normal. So things that are showing up white on this scan, this is a stir scan. It's fluid that is showing up white, particularly. In here, he has a fluid-filled sac that looks like he's got a paraspinal abscess, and he's got this inflammatory material that has collapsed within his spine itself. This is very characteristic for a spinal abscess, almost certainly looking like tuberculosis. How do we prove it? Well, we do a few additional tests. We have blood and sputum cultures. They are sterile. So sputum cultures, despite him having an abscess, doesn't show anything that looks like he's got mycobacterium. He has staining for mycobacteria. Now remember that mycobacteria don't stain with a gram stain, so you need to specifically ask them to do a stain such as usually a Zeil-Nielsen stain, and that showed nothing. We did a CT of his chest, which confirms he's got this cavity, and we've done a blood test called an IGRA. There's different brands of IGRA. T-spot or quantiferon are the commercial names, but they are collectively called interferon gamma release assays. Really cool tests, and I'll just take a moment to explain these to you. They are a test whereby you are trying to see if someone has ever been exposed to Mycobacterium tuberculosis, one of our oldest, most feared pathogens, still a cause of enormous morbidity, mortality globally. The thing about tuberculosis is the immunology of it is our host response is predominantly T-cell mediated. You don't get an antibody response. So unlike most bugs, if you said, how do I know if someone's had, I don't know, hepatitis or pneumococcal pneumonia, you can do an antibody test. You can measure your hepatitis serology. You've all had that done as part of your occupational health. If you want to test someone's immunity to pneumonia, if they've had a vaccine, you can do their pneumococcal antibody titers. There is no TB antibody, though. Tuberculosis is an intracellular pathogen. You don't get any consistent antibody response. So to try and test if you've had exposure to TB, you need to do an IGRA. And IGRA testing, interferon gamma release assay, you take a series of blood samples, 3 tubes, and in the first tube, what you do is you add some bits of protein, or mitogen as we call them, that will make any T cell go crazy and produce interferon gamma, a cytokine produced by T cells in response to a stimulus. So if you put a drop of mitogen in and the T cells all go crazy, that's your positive control, tells you this person's T cells are working. I'll explain why that's important in a moment. The second tube is you put some TB antigens in, some proteins only found in TB and importantly not found in the BCG vaccine, so you don't get cross-reactivity with someone who's had a BCG vaccine in childhood. And if that's positive, then it tells you this person has responded to TB exposure before, they've seen it before. The third tube, you put nothing in, and that's your negative control, because if you get a T cell responding there, that tells you that probably the sample's been mishandled, and you have to just ignore the whole test. The reason the first tube, that positive control, is really important is the positive control is able to tell you if the T cells are working. So imagine you've got a person with HIV, then you will often find the positive control fails. And that means you can't interpret it either because their T cells are just anergic and not working. Now, here's the question. If you see someone who has got possible tuberculosis, and I showed you that chest radiograph looks very suspicious for tuberculosis. But could it also be lung cancer in someone who's lived in Cameroon in their early life? They have had prior exposure to tuberculosis. Well, I'm afraid, unfortunately, the IGRA test doesn't distinguish between whether this is a cavity due to tuberculosis or whether this is a lung cancer. It could be either at the moment. So the way to diagnose tuberculosis is with imaging, is with histology. So what we did at this point was we got a more imaging, but we got a spinal biopsy. This is what I was looking to show. The spinal biopsy confirmed he had got in his spine histology consistent with tuberculosis. Now, can I check, is the audio working well?
Yes, there's no issues.
Okay, this is hopefully going to work. My anxiety is whether or not the audio is going to share with this. Let me just check I'm sharing audio. What I'm going to hopefully show you now is our histopathologist discussing the slides.
So for those people listening, I've got with me John Salisbury, who's one of our consultant histopathologists. John, you've had a look at some tissue from the bone. Are you able to let me know what you found?
Can I check, is that audio working?
Yep.
Okay.
Yes, of course. This biopsy was taken from the lumbar spine, and we received 2 needle aspirate cores. These tend to fragment once they've been taken, particularly if they're diseased. And so the pieces that we're going to look at are fragments of these lumbar bone biopsy cores. I'll start sharing the screen now. And what you can see at the low power are these fragmented pieces of tissue. And I think the first thing that strikes you is that there's nothing here that looks particularly like normal bone. Much of the tissue appears to be necrotic. And if we focus down on some of these pink areas which represent the necrotic part, so for example, in the center of this core here, you can see the tissue is necrotic, but not only is it necrotic, it is actually featureless in the sense that whatever the cells, bear with the camera a minute, finds it. Whatever the cells that were here before have completely disappeared. When we look at most necrosis, we can see the outlines of the cells. So that's coagulative necrosis, where the outlines of the cells are preserved. Whereas in this case, we've got a rather sort of eosinophilic, that's very pink staining, amorphous necrosis. And that's typical of the type of necrosis that is known as caseous necrosis or caseation. So the fact that this necrosis is featureless, that there's nothing here that looks like the original tissue, is already making us think, could this represent tuberculosis? Because that's by far the commonest cause of caseous necrosis. There are other causes, things like fungal infections, for example, some of the deep systemic fungal infections, but they would be uncommon in the UK. And certainly in the United Kingdom, the large bulk of caseous necrosis is going to be due to tuberculosis.
That would certainly fit with the clinical presentation.
When we can see other changes in these slides that would lend support to that, in that when we start looking at the viable tissues next to it, we can see that what we have here is chronic inflammation. And this chronic inflammation is a mixture of cells. The very small dark cells are lymphocytes. In some areas, such as up here, can you see that pointer?
Yeah.
Yeah. These cells are plasma cells, but all of these small dark cells are lymphocytes. And then these rather elongated looking cells are not fibroblasts, but are epithelioid macrophages. They're macrophages that have altered their appearance and taken on a secretory type of phenotype, so that they're producing lots of cytokines. And the cytokines that they're making are in some ways responsible for some of the necrosis that we can see. So that mixture of chronic inflammation rich in histiocytes often forms discrete granulomas.
So I'll stop there. That was John Salisbury, who's a colleague of mine in the histopathology lab, presenting the slides from there. The case I presented to you, I wanted to start with this case as an example of the sort of thing we get referred in rheumatology. He was presented with fevers, weight loss, and back pain, and actually the final management of him. This was he presented in the pandemic, and this is a colleague of mine who's one of the respiratory physicians looking somewhat distressed by the pandemic. Jack Barker, superb clinician, and absolute authority on the management of tuberculosis, and he took over the patient's care and treated him for TB. The thing I wanted to highlight was, in rheumatology, a big part of what we do is diagnostic workup for people, where the question is, could this be autoimmune disease? Could this be infection? Could this be cancer? And that, in terms of our inpatient workload, is probably the most common scenario, because autoimmune diseases can present with fevers, weight loss, night sweats, musculoskeletal pain, organ involvement, splenomegaly, all of those things. And there is an enormous array of autoimmune diseases. And quite often, the point at which we're called is the point at which someone isn't responding to antibiotics. So it's not a common or garden infection. It's one of the other, maybe less common infections or resistant infections like tuberculosis. And if you're not familiar with the tuberculosis treatment regime, on the right, it shows you there rifampicin, isoniazid, pyrazinamide, ethambutol as the standard 4-line regime we'd use. One thing you may notice is you may not recognize any of those names as familiar antibiotics from common prescribing, amoxicillin and flucloxacillin, and the type of antibiotics that are commonly prescribed for community-acquired infection wouldn't be effective to treat tuberculosis. The key to diagnosing this patient was probably picking up the history of where he had lived, that travel history. This is the global burden of tuberculosis, and recognizing the travel history is a really key part of when we take a history. I would be interested, I don't know how many of you on this call regularly take a travel history. I would strongly encourage you to nearly always, if you're taking a full medical history, Clarkington, always take a travel history. For perhaps the most important reason is it is a great way of bonding with your patients, just saying, well, where have you been of late? Where did you grow up? And trying to understand that occupational exposure, the environmental exposures, can be a really good way of that bridge, that creating that doctor-patient relationship. Tuberculosis is also notorious for causing musculoskeletal involvement. The picture on the right is a very old photograph capturing this disease of the spine, what used to be called Pott's disease of the spine. The combination of spinal curvature and weight loss was a notorious presentation of tuberculosis from hundreds of years back, and often referred to as the consumption. We still see it today. And the thing about tuberculosis is its presentation is often very indolent, over months or sometimes even a year. I'm going to go on to my second case now. So this is a young girl. She's 17 and she's been transferred over to my hospital with fevers without a cause. She's actually been in and out of several hospitals over the last year. Up until about a year ago, she'd been in a usual state of health. But then in the last 12 months, she's been in and out of hospital 4 times, each time with an undiagnosed febrile illness. Each time she was managed with a combination of broad spectrum antibiotics, IV fluids, and discharged again. And she got better each time, but a few things. She was never proven to have a particular infection and never quite makes it back to her baseline state of health. So attendance at school going down and tired, feeling like something is not right, but no diagnosis ever being reached. The first admission, she was at school. She develops abdominal pain, fevers, not much else to point to a focus though. No cough, no urinary symptoms, no diarrhea, no headache. She was tachycardic, she had a racing pulse, but didn't have any pain with that, and she's young, hemodynamically, other than the tachycardia, not much else. The first admission, her bloods didn't show much other than an elevated CRP, so a non-specific marker of inflammation. She gets better over a week, and the antibiotic they gave her was Coamox. The next admission was similar, but rather than abdominal pain, it was chest pain, and they did an echocardiogram, and that showed she had a pericardial effusion. Not massive, not constrictive, but it was sort of the one positive finding. Again, the CRP is elevated, this time at 108, and she's, over the next couple of weeks, treated with a mixture of antibiotics. Coamox initially, then piperacillin, tazobactam, tazocin, and again, she improves and gets better. Goes home, not back to baseline. The third admission is more protracted. Daily fevers, this time for almost 3 weeks. This time, she doesn't have the effusion around the heart, but she does have fluid in the abdomen. So she has a CT abdomen, which shows she's got some abdominal fluid, some ascites. She also has some skin rashes, which she describes being acne-like on her face and arms that appeared during this third febrile illness. This time, the CRP even higher, gets to 200. On discharge, again, she says she's been better than on admission. The CRP had come down, but she's still febrile, she's tired and definitely not well. The fourth admission, she comes in to us, and on arrival, she's clearly distressed and pain. Temperature 39.7, so high fever. Widespread rash, which is this sort of bullous hemorrhagic rash that you can see on the leg here. And we are trying to work out what's caused all of this. I don't know if anyone has ideas at this point. I was obviously concerned about her and looked at the history, bit of background. She's born in the UK. Mum's from central UK, dad from Spain, but lived in the UK. She's a student. She's a cat. The cat is 10 years old, sleeps in the bedroom with her. Interestingly, she says the cat often scratches her legs, and there were some scratches on the legs. And I do remember saying, you know, I wonder if that could be related. There's this condition you can get from cats called cat scratch disease. Although if you've got someone whose immune system isn't quite up to normal, you can get quite ill with it. So you can get something called bacillary angiomatosis. We used to see that back in the HIV days, and it can cause this. Well, they can get this bullous rash, which can be hemorrhagic in appearance. Usually you get these sort of little pedunculated, blood-filled lesions on the skin. But the other thing about that, cat scratch disease is caused by an organism called Bartonella hensellii. Now that is not only a difficult organism to diagnose because it doesn't culture. You need to know you're looking for it to try and find it, either with molecular diagnostics or serology. The other thing is also doesn't get better with piperacillin, tazobactam, coamoxiclav, the standard antibiotics. You'd need to give doxycycline. There's a bit more history as well. There's a history of been to Spain to see an uncle, rural house, dog, walks in shrubland, sees ticks. What about tick-borne diseases? There's a particular infection called scrub typhus, organism called Orencia susukamushi. I think one of my favouritely named organisms. Could that be part of it? We chatted about this and said, well, maybe we'll try her on some treatment. There was a rather unfortunate event because I said we could try this and put her on some doxycycline, and she said, oh, that's okay, well, I'll try that. Over the weekend, her fevers got better, and I came in on the Monday, and she said, oh, yes, it's all much better, so it must have been the cat. And so we've had the cat put down. Crumbs. I thought that was a drastic. I didn't think that was necessary. I also, on the Monday, got back the results of both the scrub typhus and the Bartonella results, and both of them were negative, which we had to inform her a few days later, and it probably wasn't ever anything to do with either of those, and we had to keep searching. The things we went looking for, so imaging of the lungs, and you've seen chest imaging earlier today, but just to look here, looks like this is, again, not labeled, so I'm going to assume it's a PA film. The exposure is good. It's slightly more rotated here. See how the clavicles are not quite so centrally around the spinous processes, but we'll do our best. The trachea appears to be central. The lung fields, I can't see any pleural effusions. I can see aerated tissue to the lung margins. There's no pneumothorax. Just looking, I'd say maybe there's some patchy, slight haziness in the lower zone on the right, but it's subtle, nothing dramatic. The cardiac contours look normal. The bone structures look normal. I can't see any free gas under the diaphragm. I think this looks like a relatively unremarkable chest radiograph. Bloods, so we've got lots of bloods back. I've not shown you the full blood count, but HIV negative, hepatitis negative, CMV, EBV negative, blood cultures, multiple sets negative, a skin grew staph epidermidis, which is a commensal on the skin, urine culture sterile, HSV, VZV, meningococcus, a BD glucan, which is a marker for fungal infection, a T-spot, which is another name for the egra, all negative. The thing I wanted to share with you here, what I want you to capture is that we are looking really hard for an infectious disease and we cannot find one. Got a PET scan, and this is a PET CT. So this is a CT scan done, but we've done it with an injection of fluorodeoxyglucose. And the fluorodeoxyglucose will pick up, it is able to identify, here we go. It is able to identify metabolically avid tissue. And what you can see here is we're scrolling back and forth through the body. Well, first of all, in the middle of the screen, the kidneys. That is normal. That's just the tracer being cleared through the renal tracts. That's just metabolic clearance of the tracer. But I hope you can make out there is a liver, which is on the left-hand side of the screen, and on the right, there appears to be something full of these little round areas. These are abscesses, and that is the spleen. So there's a massively enlarged spleen with abscesses in it. And that is not normal. That something is odd there. And then we get one other piece of the puzzle. She has oral ulceration. In fact, some quite deep ulcers, both on the mouth and actually on questioning, also on the genitalia. The diagnosis here, and I think this is where, if you were interacting with me, I hope someone would be jumping, saying, could this be Behçet's? And this is indeed Behçet's. She was positive for the gene, the HLA-B51 gene, which is the gene associated with Behçet's syndrome. Behçet's is one of the rare rheumatic diseases that we see in clinic, and it is one of the classic diseases that is associated with a very typical, long drawn-out history of multiple appointments, multiple assessments by lots of different specialists before anyone puts it all together and reaches a diagnosis. It was first described many, many years ago. We're talking 1,000 years ago. It's a disease that is characterized by this triad of inflammation of the eyes, the mouth and genital region, and an arthritis often, although it can affect all manner of other organ systems, the heart, the lungs, the abdomen, and the skin in particular. It's a disease that is more common. The ethnicity is important, so it's associated with this gene, the HLA-B51 gene, which is often described as being present along the Silk Route. The HLA-B51 gene is actually quite uncommon in people who are from Northern European descent, but in other parts of the world, and in fact, including Spain, where her father was from, it is much more common. My clinic, I've got a handful of people with Behçet's. My colleague who works in Istanbul has 1,000 people on the books with Behçet's. So it's a quite regional variation in the disease. And it has this characteristic presentation with orogenital ulcers. Often they get uveitis, inflammation of the inside of the eye, and the rash is typically an acneiform rash, looks like acne as shown in the photograph here. This is a very nice case written up in the New England Journal of Medicine a couple of years ago, which describes the disease very well, if anyone wants some extra reading on Behçet's. And actually our patient responded very well to immunosuppression. The immunosuppression for Behçet's is, for mild disease, we'll often just give them some steroids. Sometimes we use colchicine. For more severe disease, we'll often use an oral immunosuppression drug like methotrexate, azathioprine, mycophenolate. And more severe disease, we use biologic drugs like anti-TNF therapies. And actually, she went on to an anti-TNF and has done exceptionally well on it. Next case, and I am going to so I'm going to go through this case slightly more quickly. This is a case referred to in the wards as, could this be someone who's got septic arthritis? She's 58 and she's got a history of psoriatic arthritis. So I think of the rheumatic diseases that we probably most see in the outpatients clinic, inflammatory arthritis like rheumatoid, psoriatic arthritis and ankylosing spondylitis are the most common diseases we see. And if I was going to give guidance for medical students to study rheumatic diseases, these would be a starting point. This patient's 58, she's got psoriatic arthritis and been admitted for severe wrist pain. Could this be infection? So the background is she's had psoriasis since childhood. She didn't get arthritis until she's in her 40s. And actually, in the context of psoriatic arthritis, that's not uncommon. The skin disease can predate articular involvement by decades. Remember, psoriasis is very common, affecting maybe 4 to 5% of the population. Psoriatic arthritis only occurs in about 1 in 10 people who get psoriasis. And typically, it'll often affect just one joint. And then in some people, it can cause a pattern that looks very similar to rheumatoid with polyarticular disease. In other people, it can be oligoarticular. And some people, it can look like ankylosing spondylitis and affect the spine. In this case, it started in just an elbow. Then it affects the shoulder and then a knee, and the last couple of months, the wrist. On the right, you've got some photographs showing you psoriasis. I think it's sometimes useful to look at photographs of psoriasis because the first thing I'd say is location is everything in psoriasis. Location, location, location. So important. I know you had a talk from a dermatologist recently, but knowing where the skin is it a photosensitive distribution? Is it flexural distribution? Psoriasis particularly loves over the extensor elbow surfaces, also the hairline and in the ears. The other thing I wanted to show you on this photo is just to remind you that when you look at skin disease, it's always important to see how different skin disease can look on different skin tones. So this wrist pain, it's got worse progressively over the last few weeks, and it is now 9 out of 10 severity. She's unable to grip anything, unable to use the wrist. She's feeling ill, poor appetite, losing weight, and very tired. This is a photograph of her showing how she can't fully flex or extend that wrist on the right-hand side compared to the wrist. You can see it's visibly swollen. The lab data, so just a quick run through. Hemoglobin, she's low, she's anemic. That's a bit odd. Don't normally get anemia in psoriatic arthritis. The bloods, nothing too much to say about the bloods in terms of the lymphocyte, neutrophil counts, total white count. Yeah, so if this is an infection, normally you'd expect a neutrophil count to go up, a neutrophilia, high white cell count, which makes an infection maybe seem a bit odd. And the CRP is very high, 212. too high for psoriatic arthritis in some ways. We got a chest X-ray. So again, we'll just have a quick look at this. So it's doesn't say PAAP, so I'm going to assume it's a PA film. It's slightly rotated, but not too bad. I can see the trachea central. Lung fields, I can see lung markings to the lung peripheries. There's no pneumothorax. There's no pleural effusions. I just wonder if the lung bases look abnormal. I wonder if there's some sort of slightly scattered reticular shadowing in the lung bases, maybe both sides. Maybe that's just my sort of eye of wondering. But anyway, I'm not sure about the lung bases. There does appear to be some haziness in the lung bases. Cardiac contours look normal, no cardiomegaly. It's borderline, but I haven't measured, but it doesn't look definitely large. And then let's just think about looking. Diaphragms look clear, and anything else. You know, I don't know how hard you're all looking at this chest radiograph, but I can tell you there is something striking on this chest radiograph that has been missed on my description. And if you look closely, and this is hopefully going to stick in some of your minds, the clavicle on the right-hand side of the screen, her left, has got a very abnormal looking clavicle. In fact, it looks completely eroded away. If I didn't know better, I'd be worried that could be something very sinister in there, like an infection in the joint. That is a severe erosive clavicle disease. And the chest CT, when it's done, shows that there is this basal fibrotic appearance. It's quite peripheral, looks almost a little bit honeycomb-like, looks like there may be, this is what we call non-specific interstitial pneumonitis, like there may be some lung fibrosis. And we get an aspirate from the wrist and get quite a lot of fluid out of the wrist, which is very inflamed. So the diagnostic test, though, is not from the wrist. It's from the blood antibody levels, because she has got both rheumatoid factor and CCP antibody in very high titer. So actually, this case, we did go on and we did a biopsy. We did a synovial biopsy to try and say, is this rheumatoid arthritis or is this psoriatic arthritis? Because she's clinically behaved much more like rheumatoid. So remember, rheumatoid arthritis typically will present with symmetric polyarthritis going for the small joints of the hands first. It's associated with these antibodies like rheumatoid factor and CCP, the cyclic citrullonated peptide antibody. And it also associates with extra-articular manifestations like interstitial lung disease, as she had. And it will often associate with anemia of chronic disease. People can lose weight with it. It's very inflammatory. It'd explain that very high C-reactive protein, and it would also explain that eroded clavicle, that bone in the shoulder joint that I showed you that looks so damaged. But she's also got psoriasis, and she'd had the label of psoriatic arthritis for many years, and the presentation in her joints was very typically like psoriatic arthritis, a mono, then oligoarticular pattern. So a biopsy was what helped us confirm, and the biopsy showed characteristic findings of rheumatoid. We changed the diagnosis to rheumatoid arthritis and commenced on treatment for rheumatoid with rituximab and methotrexate, and she did very well. Now, those are 3 cases. It is 1:45. I'm happy to take some questions or do my final case. What would people like? Shall I keep going?
Yes, there doesn't seem to be any questions just yet.
Okay, and I've no idea if anyone's still listening or not, but if you are still listening, I'll go on to my final case. So this was a 43-year-old man I was asked to see on ICU post VT arrest. It was a request came from the cardiologists. They were called to see him, and they said, could we see him as well? Is there a unifying diagnosis? Oh, thanks on whoever said that in the chat. Thank you. So there's an interesting story. So 43-year-old man collapses in the street. There'd been some clues. So he's had a few months where he's been getting episodes of palpitations. When you ever take a history from someone from a cardiology perspective, you think, you know, what's the cause of palpitations? Palpitations are really common, but when are they sinister and benign? Well, a really good question to ask is to just capture the information about the speed of onset and offset. If someone says to you, you know, I got palpitations yesterday, I'd been up a flight of stairs, I was getting palpitations. Tell me what it was like. Did it come on suddenly, or did you just become aware of it gradually? And they'll often be a bit vague, so I'm not sure. I think it came on suddenly as I went up the stairs. Okay, tell me when it stopped. And they say, oh, well, it lasted maybe 5 or 10 minutes. Then you are much more reassured. Did it stop like it just faded away and slowly come back to normal, or did it switch off? Oh, well, I think it slowly recovered. Again, you're reassured, because tachyarrhythmias, the nature of them is they tend to switch on and switch off. So the person who had an SVT, or more worryingly in this case, probably a ventricular tachycardia, they will say, yeah, I went up a flight of stairs and I felt suddenly like something jumped to my chest and my heart was racing. It lasted maybe a minute or two, but it felt like longer. And then it stopped. And that sudden on, sudden off is the characteristic description of an arrhythmia, as opposed to what most people who feel their heart beating are describing, which is just sinus tachycardia. When you're anxious or nervous or lying in bed at night and you feel your heart go boom, boom, boom. And it's gradual to become aware of it, and it slowly fades. That, and it often lasts for quite a long time. That is a much more benign description. Learning about those descriptions of arrhythmia is really important, because you mustn't miss the description of someone who's having episodes of VT. And in fact, this one, he had an episode at work last week before he came in, and he actually blacked out with it. He dropped. And so syncope, always on your list for syncope, has to be arrhythmia. Yesterday's episode that brought him into hospital happened in a supermarket. Paramedics were very nearby. They got there and confirmed he's in VT. They cardioverted him. He gets to the hospital. He's in VT again. Once he's in hospital, here's his ECG, broad complex tachycardia, and they try to cardiovert him. This looks like ventricular tachycardia. It's interesting. If you ever want to know how do you tell the difference between VT and SVT with a broad complex. So those of you good at ECGs may be thinking, well, this is very monomorphic, but could this be SVT in someone who's got pre-existing bundle branch block, or is this VT? And it can be tricky, although here's a very simple way of doing it. When you're standing at the side of the bed, and you'll look so impressed if you can do this, you're standing at the side of the bed, the patient's there, their blood pressure's, maybe 110, on the low side, could be VT, could be SVT, and you look at their neck veins, and you've all been taught, I hope, about examining the cardiovascular system, and you're looking at the JVP. And when do I ever actually really look at the JVP? And this is a great example, because in someone who's got sinus tachycardia or SVT with bundle branch block, the JVP will be unremarkable to look at. In someone with ventricular tachycardia, however, what you have is atrioventricular dissociation. The AV node is not conducting, and so as a result, you'll be getting contraction of the right atrium independent to the ventricle. The right atrium will be contracting against a closed tricuspid valve. The result being, every time the right atrium contracts, the pressure is reflected in the neck vein, in the JVP, rather than going down through the tricuspid valve. And that gives what is called canon A waves. If you're interested, Google canon A waves, because it's a physical sign that at the side of the bed is really helpful in helping you then interpret and correlate with the ECG finding. So what happened? He's transferred to ICU. They repeatedly try and cardiovert him, but it's not successful. They intubate him and ventilate him, put him on an amiodarone infusion, and the plan is that they're going to get him worked up for an implantable defibrillator. But what caused it? They do some investigations. They have a bedside echocardiogram that's normal. They screen him for drugs that's negative. They do an infection workup for common things, bacteria, but also uncommon things like Lyme disease, all negative. They do a chest radiograph, which I'll have a look at with you. It's a, well, this does label it. It's an AP film because he was sick. He was in hospital. And looking at it, he's lying on a bed. I can see it's a little bit rotated, but not too bad. It's not as well penetrated as some of the other films I showed you. The trachea looks central. Looking at the airways down to the B breathing, I can't see any pleural effusions. I can see lung markings to the edges. There's no pneumothorax. Cardiac contours look normal. Can't see any gas under the diaphragm. Bone structures look normal. And here's his bloods. Hemoglobin, normal range. White count, 22. Hard to interpret that though, because he's just had a cardiac arrest. Neutrophilia high, yeah, I don't know, could that be infection or just a complication of him going up in an arrest? Kidneys look fairly unremarkable. CRP 11, it's a bit discordant with the white cell count, which makes me think it's maybe not infection. It's a bit odd as well. Infection, normally ill for a few days, fevers, whereas it came on out of the blue, collapsed, cardiac arrest. So how did we unpiece this? Interestingly, we looked at the GP records and there was a clue. He's a landlord. He currently works, he looks after a pub. He was having a pub renovated and he's normally in good health, but recently he's had a trouble with one of his tattoos becoming inflamed. The tattoo is shown in the picture here. It's particularly the red ink areas of the tattoo have become inflamed. And in fact, he'd seen his GP and tried to get some antibiotics for it. That was number one clue. Number two clue is, I'm just going to go back to his chest x-ray. In fact, I'm just going to start with the normal chest x-ray. So I showed you a few chest x-rays today. I showed you some things to look at, and here's some key arrows pointing out the heart, the left ventricle, which is over to the left-hand side, the right atrium, which sits behind the spine when you look at it, the hilar region. Notice I hadn't commented on the hilar region. I sort of omitted that, which may be an intentional oversight. If I was to add in as well the carina, that bifurcation between the right and left main bronchus. And then here's a couple of places. If I was to pick up on places that people miss things on a chest radiograph, things that sit in the aortopulmonary window, or things that sit in the para-aortic region behind the heart, or things that sit adjacent to the trachea, so the paratracheal stripe. These are areas you need to train your eyes to look at, because on the x-ray I showed you rather fleetingly for this patient, he has got this very striking enlargement of his of the paratracheal stripe. In fact, on his CT scan, he had enormous mediastinal upper and central mediastinal lymphadenopathy. There were some other clues as well. We CT'd him, which confirmed that. We also got an ophthalmologist to have a look in his eyes and confirmed he had got uveitis. Although he had not had any symptoms, he had had inflammation. His blood test showed he got an elevated serum ACE, slightly elevated, but he'd got a really strikingly elevated soluble interleukin-2. And as I said, on the slit lamp exam, he had evidence of uveitis, inflammation in the eye. He also had a PET scan, and I've shown you a slice through the PET scan here showing everything lighting up red is abnormal. So his heart is lighting up, so he's got cardiac inflammation, lots of lymph nodes lighting up, both under his arms and his mediastinum, lesions lighting up in his liver and spleen, and a lymph node biopsy, which showed, and this is sort of the top and tail of this presentation, a granuloma. Except unlike that very first patient where John Salisbury presented to you a granuloma, which was caseous, this is not. This is a well-formed granuloma. So central here, you see these big cells with, these are macrophages surrounded by these dense clusters of lymphocytes, creating that rim, which is what a granuloma is. Lymphocytes surrounding some macrophages. And a non-caseating granuloma, a major differential is a disease called sarcoidosis. And that was what we diagnosed him with. And the tattoo was also sarcoidosis. So he was diagnosed with multi-system sarcoid, started on treatment with methylprednisolone, methotrexate, and he's had a good response. He also had to have an ICD implanted to avoid, if he ever did go into VT again, that he wouldn't black out. It would shock him straight away. So I presented to you 4 cases, spinal TB, Behçet's, rheumatoid arthritis, and sarcoid, covering a sort of spectrum of the things we see as rheumatologists. I wanted to try and capture that in rheumatology, history taking is an art. It is all important to understanding where people have come from, the clues in the history, the evolution, the speed of evolution. Diagnostics in any specialty are challenging, but one of the things that rheumatology does that is distinct is we are very multi-system in the diseases we look after. As you see, we work with infectious diseases, dermatologists, doctors, cardiologists, respiratory physicians, and many more. And the challenge in rheumatology is often trying to pick out what is just a common disease with an unusual presentation versus a rare presentation, what is rare presentation of a common disease versus a common presentation of a rare disease. You've always got to be careful in clinical practice about how we make diagnoses. And one thing you sometimes get told when you're training is if you hear hooves, think horses, not zebras. And that is true. But the other side of that is if you never look up, you'll never see a zebra. And rheumatology is especially with perhaps its fair share of zebras. So I will stop there. I have a QR code, which I was, I think, hopefully will. I've got to be honest, actually, I'm not sure where the QR code will take you, but it is related to Synapse, and so please sign up. I think it's to join the group chat for Synapse. Let me see if there's any. There's a question that's come up, which is, can I go over Pott's disease? Yeah, certainly. So Pott's disease is a description of tuberculosis of the spine. Specifically, the original description of Pott's disease were of people with a sort of very extreme curvature of the spine due to a spinal fracture. When you get tuberculosis of the spine, you'll often get spinal instability and you'll get fracture often of more than one vertebral body. And so you get this very characteristic stooped posture. If you see tuberculosis in the UK, you should not see Pott's disease because it would be uncommon to see that in someone who's been treated for TB. It's generally people who've been left with a very chronic disease and they've not received treatment in a timely manner. So we see it rarely in the UK now, but it is still present in other parts of the world and in low middle income countries. Okay, well, it is nearly 7 o'clock. So I think if there are questions in the chat, but otherwise, have a good rest of the evening. Enjoy the rest of the sunshine. I'm getting the sun. I see it's blurring my camera a bit actually, but I hope that was useful. Thank you for listening.